Hello people, just updating you here on the interview that I had at Dr. Kim's office. If you haven't seen any of my previous videos, I highly recommend that you go through those first. The first three or four are kind of long, but it gives you the background that you need. And today I went to Dr. Kim's office and actually spoke with the surgeon, his partner surgeon there, Dr. Bridget Holden. And I got all of, I got most, if not all of my questions answered there. And that's what I wanted to give you today, were the answers to all those questions. I had previously, I've got these questions posted underneath a previous video, and I'm going to go back to and put all of this with the answer that I was given underneath this video. So be sure and watch for those there. And I'm sorry about the lighting. I'm in my upstairs office again, and it kind of comes in and out. And I've also got this cold, so if I have to cough or something, pardon. I'm sick as a dog, as they say here in Texas. Alright, so when I went in, I weighed in at 212 with a BMI of 33.3. First question I asked, first of all, Dr. Holden's personality was fine. She had no problem answering all of my questions and answered them thoroughly and was gracious to answer them. And after a little bit of time started going by, I started realizing that most of the questions I was asking about were a little bit over the top, not because she made me feel that way, but I started to gather that for myself just because they take such care in the technique that they use, that they have particular ways that they do it, and they do it that way for the safety of the patient and for the best outcome ever. And so my questions were geared around, you know, do you guys do this procedure this way, which according to the literature makes it more safe? Well, they already do it so safely. They do it as safely as possible. It's the lowest complication rate I've heard out of any of the doctor's offices that I've talked to. They said that they have a 0.01% complication rate, and they have done they've done the sleeve for 9 years there, which is really cool, I thought, because I didn't realize they'd had quite so much history. I knew that they had 6 years, but I didn't know they had the 9. So that was really awesome to hear that. 0.01%, that included that included all the complications lumped together in one bucket. So that would include death, leaks, strictures, bleeding, internal bleeding, pulmonary embolism, things like that. Okay, so I've got the scoop on all that too, and I'll get into that here in a second. The data comes from 30 days after, or 30 days post-op, which I thought was great too, because I had come across a couple of resources that made me believe that the data was only from just a day or two after surgery, or maybe even the surgery day, where they said, okay, we did not have a leak on this staple line on this VSG today, and then the data stopped. So that's not the case with Dr. Kim's office. They gather that data for 30 days post-op. So their 0.01% complication rate comes from 30 days post-op that includes all of the possibilities of complication, and it's 0.01%. First question was, do you immobilize the posterior of the stomach prior to cutting? So in other words, do you cut that stomach away from what it's stuck to, sort of behind there where the spleen is and the appendix, maybe? I can't remember what else back there, but they do immobilize that. So that was a big deal. And she kind of looked at me funny, like, well, we have to do that. And I said, well, that's kind of what I thought too, but I've seen a video where they didn't, and it was really clunky and messy looking. So I'm glad to hear that you feel that that's just a basic thing that has to be done. So that's great. I said, can you tell whenever there's been a staple that's defective after it's fired? And she said, yes, we can tell, because we go in and we take a look at it and we look at all the staples to see how they went in there, and if one of them was a misfire or didn't fire or something like that, because there's so many of them there along the line of where they staple. She said that they would stitch it right there. They would put a stitch in to reinforce that spot. I looked at a foam demo that they had there. It was like a foam stomach that was cut out of just styrofoam, and I was able to look at the staple line and how it fit onto that foam, and it was pretty realistic according to what her description was as far as the thickness of the stomach. Interestingly, she said that men's stomach tissue tends to be thicker than women's, just across the board, and they generally use a different size staple cartridge for men than they do for women. So, well, let me take that back. I'll clarify. She said they use the same staple cartridge across the entire staple line for women most of the time, whereas men, because they have a thicker stomach wall, I don't know if it's all men, but she said men tend to have thicker, then they will go to a different cartridge at some point in time along the stomach. So it made sense to me. I asked if she had any reason to believe that people who eliminated their ghrelin hormone from their body, that they would end up with some sort of a osteoporosis or some kind of other Alzheimer's or something. You know, it's like, what else does ghrelin do that we don't know yet? And she said, well, that's just it. We don't know exactly what ghrelin does other than stimulate hunger. And she said all the literature up to this point does not indicate that ghrelin is for anything else. And so she said that there would not be any reason to believe that there would be a issue with either of those things that I mentioned in 10, 20 years, 30 years down the road. And being that VSG is not a malabsorptive procedure, then it's not going to cause there to be like a tendency for osteoporosis or spinal fractures and things like that. So she was very low key on that. She said that should not be an issue. We're not seeing that in the literature. I was good with that. I also asked her if they use a 32 French bougie size. She came out of left field and said they don't use a bougie. I said, really? What do you use? And she said they use hang on, let me look at my note. They use a endoscope instead of the bougie. And they said that the endoscope that they use is more of a 34 size bougie than a 32. She said they feel like the 32 is a little small. I couldn't agree more. All the literature and the studies and just the articles over the last year and a half that I've read said that the 32 French bougie was okay, but there's some documentation that it's a little bit narrow, and a stricture is when the passage is too narrow. When it's too narrow, then you have to intervene with that. And there's a couple of things that they in bariatrics that they do. They can go in and they can stretch that out somehow. They can dilate it, or they can go in and put a stent in there, just sort of like a sleeve inside there to maybe make it a little bit bigger. And so that was one of the things I asked her about after that. I said, well, so what would you do if there was a stricture, if it was too narrow? And she said they would not do either one of those. They would not dilate and they would not put a stent in. She said that neither one works. They would just revise to bypass. And so I was actually a little bit taken aback by that. Not that it was a wrong answer. I just thought it was a little bit on the aggressive side, in that I didn't hear her say, well, we just kind of take it on a case-by-case basis. That really probably would have been something I would have expected more. But she just said, we don't think that either one of those works for a stricture, so therefore we would just revise to bypass. Okay, goodness, I hope I don't get a stricture. That would, I've got a 33.5, almost 33.5 BMI. I don't need a bypass. So I was really glad to hear that they used the endoscope that's more of the 34 French bougie size. I asked about stricture symptoms. She said that they show up, if you're going to have a stricture, it's going to come up within 30 days after the surgery. So because part of my question was, when can I relax, basically, about this and whether or not it's going to be an issue. And she said after 30 days, if it was going to happen, it would happen within 30 days. And after that, don't worry about it. It's not going to happen. Great. Love that. All right. What else? She showed me the hot spot for leaks. I showed you that in my previous video. And I don't have a blank. Yeah, I do have a blank piece of paper here. Let me draw this out. Okay. I'm going to draw a circle. All right. This spot right here, she said that is the hot spot for leaks right there, which we already knew. We talked about that in a previous video. We said, when they come up here and they do the staples up to this area here, that this is where they end up with leaks if they're going to end up with one. And she said in particular, it's this spot right up here where the esophagus and the stomach come together. And she showed me a technique that they used that was very cool. I had not seen reference to this, and I couldn't remember that Dr. Kim had told me about this. It wasn't last year that I was at Dr. Kim's office. I was actually there for a consult at the end of 2011. So time flies. I didn't realize it was the end of 2011. So anyway, just to kind of give you an idea, this area right here where the esophagus and the stomach come together, she said that right there, what they do is they take like a pleat of the stomach at the top, right next to the esophagus right there, and when they staple that, it's pleated together like that. So anyway, I thought that was really interesting, and they've been doing it that way for years and years, and that 0.01 complication rate shows that that's apparently a good decision for them to do that. So I love that too. They oversew the entire staple line. So when the staples go down, they go back and they stitch that whole incision line across there. So I liked that too. Let's see. I said, how do you avoid the sleeve, the stomach sleeve, of doing this corkscrew thing, where as it starts to heal, how do you keep it from doing that? And she said that it's when you're cutting the stomach like this. She said if you have if this isn't completely flat, if this stomach, like this is, let's say that this is the sleeve that's going to stay. She said if that part that's going to stay there isn't completely straight to where it's evenly on the front and the back, put in the stapler to where it's straight and not, like that, or, to where it's folded or something under there. She said it has to be perfectly straight, real nice and neat, and then fire. And she said when you do that, it prevents the corkscrew. Asked her if they use buttressing material. She actually wasn't familiar with that term. I thought that was so weird. I thought, buttressing material? I mean, so she said, oh, you mean the peri-strip. So a peri-strip is buttressing material. It's the same thing. It's it's just a material that sits inside the staple cartridge, and when they fire the staples, it reinforces the staple line with that material that's there. So they do that, plus oversew the staple line, and I think that's great. I think that all of us looking to do this surgery need to make sure that our surgeon does that. All right, let's see. Going down here. Okay, I talked about stricture, that they were going to show up in the first month, if they were going to show up at all, and the same goes for leaks. So if we're going to have a leak, it's going to take place within that 30 days. That's why they keep the data for that 30 days, because that's when it's most likely to happen, which I think is great, because they could easily manipulate that and say, oh, let's only take it for 2 weeks or something, and and try to cut down on the chances of us getting that positive data for a complication. But they don't. They go all the way out the 30 days. And so that would capture any leaks too that happen in that time period. So she said if you don't get a leak after 30 days, then you're not going to get one, because your tissue just overgrows that staple area. Your natural tissue will overgrow that. It's not a scar on the inside of the stomach. This is another thing that she clarified for me, because I had actually envisioned the inside of the stomach along the staple line that it would just scar over. It would scar over, right? She said no, that the inside of the stomach has its own tissue. It's interesting tissue inside there. And she said that what that does is it just overtakes that staple line on the inside. It just overtakes it, it overgrows it. And so then it's the same tissue that seals that staple line from the inside, as it's the same tissue there as it is over on the side, and whatever. It's just all will look the same. So I was really relieved by that. Now she said, now as far as scar tissue though, on the outside of the stomach where the staples were installed on the outside, she said you could have some scar tissue that would build up there, but she said they're not seeing a problem with it. They're not seeing an abundance of it. So she's not seeing any what would be considered a complication or an issue with that. And I'm sorry, that phone is probably going to ring in the background until they just decide to hang up, because my kids probably aren't going to answer it, and I'm not going to leave you guys. So we'll just let it do its thing, and it'll stop. All right, son, just all right, just click off. I'm doing a video. Okay. I asked her if the stomach is scoped periodically, and she said that it's just not necessary. I mean, she said that if there is a symptom that arises, they will scope it. But she said there's nothing, there's no protocol post-op that says that they would just scope on a regular basis just to take a look. That's overkill, not necessary. And if it was necessary, I believe they would do it. So no worries. But however, I think that, as a cash payer, if I went in there in a year and I said, hey, I just would really feel good if you guys would scope and take a look, just to give me some reassurance that everything is still okay. And if I wanted to pay for that out of pocket for them to do it, they would do it. And who knows, I may do that, may not. All right. I asked her about the sleeve being under pressure. I don't know if any of you guys are familiar with this or not, but when you create a sleeve, it doesn't have all that room in it, right? So it doesn't just sit there. Excuse me. It doesn't just sit there in that little bag, basically, of a stomach, and take its sweet time going down through the duodenum and then down into the intestine. Okay, when you have a sleeve and it's a tube, then the food that's going to be going down here, she said, builds up a little pressure. And I said, well, pressure from where? Is it pressure, like, is it pushing up this way? Is it pushing down that way? Is it actually pushing in? She said, no, the pressure, when it's talking about pressure, is that the food that is going down through here is actually pushing out and putting pressure on the inside of the sleeve to where it's pushing it out. Like if I were to blow this up like a balloon, then it's going to put pressure and it's going to blow it out that way, right? So she said that's what the food does when it goes in, and it puts that pressure. That's why it's so critical for us to stay on our liquid diet for the full 3 weeks post-op and then go into soft foods, because it's still healing. So if you put the wrong kind of food in there, it's going to create too much pressure, like blowing up the balloon, and then you could end up with leaks. So it's imperative that we follow the rules on that. There's no option on that whatsoever. And she said too, that being that it's building that pressure, it also goes through the tube a little faster. Just goes, it doesn't go through fast to where it's malabsorptive, to where you're not absorbing any of the nutrition or anything from it. It's not, of course, our stomach just helps us to digest, and then it goes down into the intestine. But she said it will travel through here a little faster than it would if it wasn't a sleeve. So I thought that was kind of cool. I asked about her, oh wait, let me go back. Okay, I said, what if you nick my spleen or my liver while you're in there? And she said, well, that's a complication that would go in our data, and that would be a bleeding complication. I said, okay. And she said, and it has happened before. And I said, well, what's your plan of action if that does happen? She said, it's very unlikely that it would happen. A lot of times those kind of things happen whenever there's an enlarged liver or some sort of enlargement that has the area a little too crowded. But she said just accidents can happen. And if it gets nicked, that what they will do is they will coagulate or cauterize or whatever they need to do right then and there to get it to stop. And then I guess I haven't really researched that much into this, and I think I will after this, but I don't know how long it takes something like that to stay permanently cauterized. And, I don't know if it can work its way loose and bleed again or what. I don't know. But she said it is unlikely, and that they would control it while they were in the abdomen so that they could finish the surgery and go on. She didn't indicate that it was life-threatening, but I'm sure there have been surgeries in the past that that they nicked a liver or nicked a spleen, and it was a problem. I have no doubt about it. But they're aware of it. That's one of the things that they retract the liver. They go in and they use a tool that retracts it, gets it out of the way, so that they can work on the stomach and not be here in the territory of it. Excuse me. I asked her if she talks to her family about the surgeries, and she said absolutely. She said she's got family around that she talks to about it. She believes in it, in doing it, and she's not a bariatric patient. She is clearly naturally fit and just doesn't have a lot of the battles that we do, but she understands them. She's made it her study. She said that she's been doing a lot of lap bands, and just they weren't really helping her patients like she needed them to be helped. And so Dr. Kim actually was, I think, looking for a partner, and approached her, and I called her and to see, kind of what she wanted to do and what her goals were. And so she said that she was interested in getting in with a practice where they did more than just the band, because she didn't feel like that her patients were getting full benefit of bariatric surgery. And so she switched over and is doing more of these. So I thought that was great, and so she does believe in it. I asked about the auto accident that I was in. I had mentioned in a previous video that back on March 7th, I was rear-ended by an 18-wheeler out on the highway where I was stopped in traffic because of construction. And an 18-wheeler loaded with oil rig equipment, apparently, according to the driver, brakes were not working as he was coming up behind me at about 25 or 30 miles an hour or so, and hit me while I was stopped and totaled the truck. Long story short, totaled the truck, whiplashed me, neck, lower back. I'm now over that, so I'm so glad I've got through that without any major issues. Whiplash is no fun, I can tell you that, but I'd rather deal with whiplash than a broken neck or a bulge or a disc that's herniated or something like that. So I've got a bulged disc anyway, and it did aggravate that, but it was mainly the tendons and stuff around. So my question was, let's say that I've had the sleeve, let's say I had the sleeve there, let's say I was a year out, completely healed, would that have impacted my internals in a way that, am I more susceptible to that? She said, she even stopped me short of completing my question because she knew where I was going with it. She said it absolutely would not make any difference whatsoever. She said your stomach is not more susceptible to, she said it's not susceptible to bursting open or anything like that. She's absolutely not. So I felt good about that answer. My BMI of 33 and my just all the anomalies that I had, my blood pressure was really high going in there today, and I think it's because the antihistamine I had taken. Maybe I was nervous because I wasn't sure if I was going to get all my questions answered, if I was going to feel good about them or not. But it was like 165 over 101. Ridiculous. My blood pressure is never that high. But including that and just the fact that I don't have diabetes yet, 0.3 of a point from it, but I don't have it yet. I have, just these other little tiny stress incontinence or whatever going on. She said that, yeah, that I am would be considered a low risk patient, but everybody has the risk of complications like the bleeding and the leak can happen, and so those things really aren't dependent upon my health, like heart failure or something during the surgery. I'm low risk for that. She said every patient has a risk for pulmonary embolism because every patient has a body. It's just that all you have to have is a body to be at risk for pulmonary embolism. It's just our bodies sometimes don't tolerate or they react somehow to just the surgery itself, just the fact that there's something foreign or something going on with our tissue. It's not like shock or anything like that, but it's like your body can detect whenever there's something going on, and sometimes there's a blood clot that happens. And she said everybody carries that risk, but what they do to lower the risk on that is they give every single patient, whether you're a low risk patient or a super obese, heart condition, existing problems patient, everybody across the board gets a blood thinner before going into surgery. And they use heparin and one other one, I can't remember. I don't know if they use both or if they use one or the other. I didn't get into that, but I thought that was really interesting. I didn't realize that they would use that blood thinner like that on everybody. I figured some patients were at a higher risk than others for that issue, but apparently not. They've had one death. I mentioned this in another video. They did have one death. It was not a pulmonary embolism. They've not had any deaths due to pulmonary embolism. The one that they had was a guy who died of heart failure before the surgery even started. So they had him under anesthesia, getting him ready to go, probably getting the ports and everything in, but never started the stomach surgery or whatever the procedure was that he was having. He had gone into heart failure prior to that. His father died at a young age. He went in with some severe underlying conditions and high risk, and he died of that. So it was not a pulmonary embolism. She felt like my BMI of a 33 was not too low, that was, being that I'm pre-diabetic and that I have the joint pain and the fact that I have gained and lost, between it. Sometimes I'll lose 30 pounds at a time. Sometimes I can, lose more than that, a little bit more over a little bit longer period of time. But being that I've gone back and forth so drastically over the last few years, that plus the stress incontinence and other things, she says that it is appropriate for someone with my BMI to intervene at this juncture and stop the train from barreling down the tracks, so to speak, rather than waiting for there to be a problem and then address it. Not to minimize those of us that are waiting until it's a problem before we intervene. I mean, everybody has their tolerances for when they're ready to intervene. I asked my pastor this today because I knew that he had gastric bypass a couple of years ago, and so I called him and asked him if you could talk to yourself 2 years ago. No, if you could talk to yourself 4 years ago, knowing what you know now about what bypass will do and that it will help you, would you tell yourself, do it sooner? Do it way sooner before you got into such a bind? And he said, probably not, just because I wasn't ready until I was ready. And he said, even if I were to be able to go back and tell myself, hey, do it sooner, he says, I probably wouldn't have wanted to. I mean, he admitted that he'd had, issues with food and food addictions and overeating and all that. And he said he needed to do something to stop that behavior. And you got to respect that. I mean, everybody has their own stopping point and their own point at which they're ready to do something. So I'm ready to stop it before it becomes a big problem. Other people are more reactive. I guess I could look at it like a proactive rather than a reactive. So what else? I asked if they ever seen any reversals of reverse problem, like are you seeing any anorexia, you know, after a year or so after somebody's had these procedures. And they said they are not seeing that in the practice. They are keeping up with their patients. She said you're required to come in 10 days after post-op, and then again at 3 weeks, and then every month for the rest of the year to finish out the 12 months. And then they want to see me once a year for life. And that's all included in my pricing there, which is $10,500. And I found out too that that sometimes there's gallbladder issues that are going on too with people, and that I should, if my insurance will cover it, then I can have that looked at as well. And I said, yeah, if they'll cover it, let's do that. And they said that if your insurance will cover it, then the hospital, then that portion of it is actually fileable on your insurance, which means your cash price is going to be quite a bit less. And so I said, yeah, I mean, if we're going to have to do it anyway, let's see if the insurance will accept the filing. He's out of network for me, so may have to jump through some hoops and get him approved or something. I don't know, but it would be very helpful. It would actually turn my $10,500 into a $5,600 out of pocket. So let's see. I asked, they do about 8 surgeries in a day. I thought that sounded like a lot for some reason. She said it's not. I said, well, so you're not exhausted? You know, like you're not wishing that you stopped at 6 when you're doing number 7 and 8? And she said, no, it's normal. It feels normal to us, and if we felt exhausted at, you know, the end, and they wouldn't do that. But she said no, she doesn't feel too fatigued or anything like that at number 8. So just have to go. And I really, what I was looking for is, you know, her demeanor when she would answer those types of questions, and she was very transparent. I felt like she was being pretty open about all of it and seemed sincere. I asked if I could get a video or photos of my procedure, and unfortunately she said no, that they're not set up for that in the ER. And I thought, oh man, that would have really been neat to be able to get some photos. So darn. And that's pretty much it. So I'm going to post these questions and answers again underneath this video so that you can go through there and be able to look at them yourself, maybe print them off. And I hope they were helpful to you. When I left there, I did feel good about choosing Dr. Kim. I said that I wanted Dr. Kim to take, I wanted Dr. Kim to take the lead on my procedure, and that Dr. Holden should definitely help out whenever it's appropriate, but that I wanted him in the lead. They did give me the option on that. And so I hope she doesn't feel offended by that. I don't think she will. I think she understands that that's just business. That's the way it is. So I feel good about that. I've chosen Dr. Kim. Final answer. You know, and I feel good about it. So they said that here, this is April the 2nd, and they are filling up May as we speak, and as we wait for my insurance to tell them whether or not they'll cover him out of network for this gallbladder scope procedure or whatever that they can do. While we're waiting on that, May is filling up, so she said that it's possible that I would not have my procedure until June. Yippee. Between now and then, I'm going to be walking. They said that best thing you can do before your procedure is just walk. You don't have to try to get into shape all of a sudden before you don't have to put yourself through that again of trying to get back into shape. We all know what that's like. But they said just walk for about 30 minutes every day from the time that you've scheduled your procedure to the time that your procedure actually takes place. Just walk every day for 30 minutes. And it helps with that blood flow and even reduces even more that blood clot issue that we talked about earlier. Okay, guys. Well, I hope you find it helpful, and another long video, but hey, it needed to happen so we can get it all out here and talked about. I will check in again soon as I hear back from the office and get the game plan. All right. Talk to you later. Bye-bye.